We will get started. We've got a giant group today, and that's great because this is a really important meeting. I think as many of you know, it's been a really exciting week for us at Aegis. We hosted our very first vaccine clinic yesterday at Aegis of Moraga down in California and vaccinated all of our residents and most of our team. As many of you also know, we've confirmed a number of new vaccination clinics. We've got about half the portfolio, half of our communities now fully scheduled. We're waiting on confirmation. But this is going to be a game changer, and it's an exciting week because it's really starting to happen after a lot of talk. And that's what today is all about, really. It's about your personal health, our personal health, our residents' personal health. And it's our job as leaders in this organization to get as smart as we can. With many clinics really kicking off next week, we recognize that the vaccine development has happened very quickly. In fact, quicker than any vaccine development in the history of our country or maybe in the world. And that has created lots of questions, lots of reflections, lots of thoughts, and some concerns. We're very aware of that. And the next hour together is really meant to address those head on, to alleviate any concerns that you have, answer any questions you have, and personally, and then empower you to make sure that you can answer those questions for your teams in your communities. We want to get everything on the table that we know to give you confidence this is a great thing for us. Many of us have done an extraordinary amount of research. Dwayne, the two physicians we've got on the phone today, many of you, we've looked at this a lot of different ways, and we're very, very confident this vaccine is safe. And in fact, it is the only thing that's going to allow us to get back to some level of normality. We know that. It is going to be a game changer. And I want to jump into this quickly, but just a few logistics. First of all, we're going to record this today so that if someone on your team didn't get a chance to see it, that you will have access to it right after this on a shared drive and can watch it again. And the second thing I want to do is just remind everybody of what our policy on the vaccine is, to be really clear, right? So we are strongly encouraging everyone at Aegis to get the vaccine. It's not widely available today. It's only available through these clinics that we're privileged to have. It's also important to know that eventually we will make getting the vaccine a condition of employment at Aegis once the vaccine is widely available. And there'll be some exceptions, those who are legally, the legal definition of exemptions related to a medical condition or religious belief. But those are really defined in the law, and those will be the two exemptions. But again, we want to get as many people as we can vaccinated because that's what's going to keep us and our communities safe. So many of you have teed up questions to me already, and we've tried to consolidate those. Thank you, by the way, for all those questions. That was awesome. Gave us a real sense of what you wanted to talk about so we could prepare. And I've tried to consolidate those and work with our two physician guests here to really try to get to the meat of those really quickly. So we're going to get started here. We're joined today by my two favorite members of the Coronavirus Advisory Council. Both are medical doctors and experts in their fields, and I've asked them to join us for very specific reasons today. The first guest is Dr. Eric Sivers. You all will know these folks because they've been on our Coronavirus Advisory Council for a few months advising us at Aegis on how to manage this virus. Eric is the Chief Medical Officer at BioAtla down in California. It's a company that's working on cancer therapies, but also developing the vaccine itself. So Eric is very, very close to this. He's got a lot of history up here in Seattle. He's been at the University of Washington. He's been at the Fred Hutch. He knows us and he knows our geographies well, and it's great to have him here. I've asked him to really focus on the science behind these vaccines today and help us understand why this vaccine is safe and how we create vaccines and why these are different. We're also joined by Dr. Becky Conant. Becky is our medical director at Aegis of Corte Madera, but she's also a superstar geriatrics physician at the University of California at San Francisco. And we've had a long relationship with Becky. She knows our business very, very well and our residents very, very well. And I've had her join us today because she has been right in the middle of the fight like we have of COVID. And she probably knows more about, she knows as much as you do about what the on the ground battle has looked like. And I've really asked her to come answer those clinical questions today about, how our body is going to react to the vaccine, and just to answer your questions around any concerns that you have. Also on the phone are Eric Smith, who is my hero this week, the guy who's leading the Aegis vaccine task force and organizing all this. And I know we have our nursing and care team on the phone as well. So we got lots of experts to field your questions. So with that, I'm going to jump into it. And Eric, I'm going to go to you first. You know these vaccines in and out. You're in this every day. And I wondered if we could kick off just by asking you to give us a little bit of an overview of the vaccines themselves and how we find ourselves where we find ourselves today.
Sure. Thank you, Chris. And I just feel this is such a celebratory moment. What you've done collectively at Aegis for your residents, for your community is really quite extraordinary. And for me, here in La Jolla, California, as a chief medical officer at a biotech, I'm just so deeply humbled by the day in, day out of what you're doing. And so in the next 2 or 3 minutes, I'm just going to talk a little bit about vaccines, how the teams approached the idea of making a vaccine. And I'm going to make this really back and forth, so it's not just a long lecture about it. But once it was made very clear that the coronavirus was going to be of major concern, several groups set out to make vaccines. And as you all know, the first two to be approved in the United States for emergency use are the Moderna vaccine and the Pfizer-BioNTech vaccine. And what they do is take a little piece of the information. So it's, I like to think of it as like a short order cook is getting a recipe for something. And the recipe is slipped in and the cook looks at it and says, okay, I can make that. And so that's the protein that's being made from that information. And very importantly, there's no virus. It's not a killed virus vaccine. It's simply the piece of information makes the spike protein. And so your body is instructed to make the spike protein from these mRNA vaccines. If we take a step back, the whole idea of trying to make the spike protein in each of your bodies as you think about the vaccine and in the residents is to try to get your immune system to see it as foreign and to develop an appropriate and protective immune response. As I think about it, when people get coronavirus as an infection, it's a foot race. So it enters through a nose or through the eyes or in the lungs, and it starts infecting cells, cell to cell to cell, and it sets off alarms, and the immune system sees it, and then it's a foot race between the immune system controlling that infection or the infection getting the upper hand and taking the life of the patient or creating very severe illness. What vaccines do is give us a huge head start by having lots and lots of antibodies, T cells, and immunity, so that it's as if we've seen it. And some people believe it's even better than having a natural infection, but the data are not fully in for that. So again, just to summarize, an extraordinary effort that began in February of last year, taking the code that was posted online. Many different groups took that information and put it into different structures of vaccines. And the first two to come out are messenger RNA-based vaccines. And again, it's put in the arm, and then those arm muscle cells take that code, read it, make spike protein, and the immune system responds to it. So Chris, I'm going to pause there and go to the next question.
Can I ask you, Eric, we've all heard that there are 2 doses, right? And I'll come back to the sort of the conversation around whether it's 2 or 1, but today it's 2. How long does it take the body? Can you walk us through sort of really tactically how long it takes the body to build up the immunity to the virus, and and what's happening in your body during that time.
Sure, I'd be happy to. So what's happening after that very first dose, and Rebecca will talk a little bit about some of the things you'll feel, some of the very typical symptoms that you'll have, but immediately, within just a few hours of getting that message, that short order cook in each of those cells is making that spike sequence, expressing on the surface of muscle cells, and the immune system seeing it. And so you'll get a sense of that happening from the achiness in the arm, maybe having fevers and chills, maybe having a little malaise and just feeling fatigued. All of those things are suggestive that that the vaccine is in fact doing its job. If those things are absent, that doesn't mean you didn't get it. You certainly are not part of the randomized placebo-controlled study, so each of you will be getting the real thing. And that doesn't mean you're not having an immune response either, because some individuals simply have less of those side effects. But fully anticipate that soreness at the injection site, fevers, maybe some chills, malaise, and fatigue would happen. And I think the best indication of when the protection really comes online was shown graphically in this Pfizer data and the Moderna data that came out as well, where right at 10 days, you can see the curves between the placebo and the vaccination split like this. So basically, there's a steady rate of infections in the placebo. And for those who got the vaccine, they followed that. And right at day 10, it split like this. And it was a flat line of no more infections. And then if you look at that across a 30,000 subject trial, there was like occasional infections. And a way to think about 95% effectiveness is that of 100 infections, 95 happened in the people that got the placebo, and only 5 happened in the arm of the vaccine. So the key points of what I've just said, number one is 10 days is right after the first dose is when effectiveness begins to take hold. And then obviously the 2-dose regimen is what we stand down as a strong foundation for the basis of the protection and the approval.
So you can assume that you've got the full immunity, that 95% at the end of that second dose, effectively.
I think it's fair on a population basis to assume that you have that degree of protection. And of course, it's not 100%, it's 95% or 94.5% for Moderna. But for all intents and purposes, it's very unlikely for people to have symptomatic infections. This might be a good moment to just address a common question, like, does that mean I can't get infected if I get the vaccine? So obviously, no. One still can get infected. One still might be able to transmit, and that's why there's still an agreement that mask wearing and all of the precautions that we're using still need to be put in place. The key thing to remember about vaccines are they prevent death, they prevent serious illness, and we have in the vaccine world have been stunned by the level of activity of these 2 lead vaccines.
And Eric, as I understand it, right, very different from previous vaccines for major things that we're trying to solve. The Pfizer and Moderna vaccines, you're not injecting live virus into the person, right? This is a very different approach.
Correct. There is no live virus involved whatsoever.
Okay. Yeah, I think that's really important for people to remember, because a lot of times in flu vaccines, right, you're getting a little bit of real flu, right? And this is a very different approach. Can I ask you to talk about safety? I mean, you're right in the middle of this right now. How does the country, these Pfizer and Moderna, how do we know these vaccines are safe? What steps have they gone through to make sure that we move to mass vaccination, that we're pretty confident that it's safe? Today, a little over 5 million Americans have had the vaccine, and about 14, 15 million people globally. Can you just talk a little bit about how science makes these safe?
Yeah, I'd be happy to. And And I want to acknowledge that for some of you, there might be some anxiety about getting this, and I have a lot of empathy and compassion for those of you who have some misgivings about that. That's fair. That's perfectly fair to wonder in your mind about this. And this is one of the very fastest vaccine approvals, the fastest vaccine approval ever. And so should that bring us pause? Sure. There actually was a pause. And that pause was for multiple groups to have a very transparent evaluation of these two data sets that led to the emergency use authorization. The process was quite transparent. So when the FDA held its advisory board meeting, there was a very thorough presentation of the data. It was not held in secret. It was held for everyone to see. And the data sets were remarkably straightforward. And one of the things that I found very reassuring was that they were exceptionally consistent between these two mRNA vaccines. So imagine this, both companies started back in February on completely independent paths, both using a very similar approach, taking the message, not the virus, the message, putting it in a little fat globule, putting it in the arms of human volunteers after doing some very quick preclinical studies, seeing that antibodies were being produced, quickly finding a dose, and then putting them both into two 30,000 subject randomized placebo-controlled trials. And then both to have essentially the same level of efficacy is really quite striking. So we're not dealing with just one company, one data set. We're dealing with two very similar mechanism of action and two nearly identical data sets in terms of their side effect profile. I'm ready to get it. I'm excited to personally get it. Yes, it's a little unnerving that it went as quickly as it did. But I just, again, this is a time for celebrating the opportunity. And I guess I would also think about this. You're considering putting a little message in your arm for just the spike protein, which is the business end of this virus. Now, you know, some of you have been exposed and some of you have had COVID-19, which this virus just casually infected your immune system, inserting its RNA, its genetic material into your cells. And then your cells made more of it. And then more cells were infected with this, which to be virally infected means to have the virus's RNA in your body being replicated. So I don't see it as even a fair comparison between the manifold complications that come with COVID-19 infection versus a very focused delivery of a spike protein genetic sequence.
Eric, I'm sure you read this in the New York Times like I did this morning, but the CDC just released some data that looked at the allergic reaction data for the vaccines on the Pfizer vaccine. And I think what I recall in the article was out of 1 million people vaccinated, 11 would have an allergic reaction. And almost all of those people were people who'd had severe allergic reactions to other things in the past. Any reaction to that? Because that seems like an astoundingly small number, despite the media that may have been out there recently.
Yeah, it's a number that doesn't surprise me, and I think it's consistent with what we're trying to do. We're trying to get a protein immune response, and so for 11 out of 1 million to have either a full formal anaphylactic reaction or anaphylactoid reaction, and when we say toid, it just means a little bit less than full-out anaphylaxis. That is not at all surprising, and I think we should set expectations that that those will occasionally happen. To kind of build on what you're saying, there has been some anxiety of rolling this vaccine out to the older population, not because people are worried about the safety in older people, but public health experts were worried that if you provide the vaccine in a population of people who statistically will have things happen to them on a regular basis, that there might be some causality ascribed to the vaccination, and there's some anxiety that might cause people to be hesitant to receive it. To my knowledge, that has not yet happened, but I want to also set expectations that I wouldn't be surprised if things like that happened.
Yeah. Well, we were on a call with a number of other leaders of companies that have started, leaders of senior living companies that have started the vaccination process, and they've had no issues to report so far, which I think is great news. Again, a small sample set, but significant. Just a couple more questions on science, and then we'll get really into the meat of the conversation. Are we going to have this vaccine every year? How long does this protect us?
We don't know. I think it's going to protect us for at least 6 to 9 months, and I think there might be some waning protection over time. It is conceivable that we will need to boost doses. The other thing that I don't want people to be scared about, but it is conceivable, is that particularly in immunosuppressed patients, they have the virus circulate a little bit longer. And the longer that virus is in an individual and having time to divide, it has more chance to mutate. And virus mutations can affect the spike protein, and that may affect the quality of the vaccinations. So that's another thing in the news these days, is whether the B.1.1.7 variant from the UK or the South African variant, whether they'll still respond to the vaccine. The data are not in yet on that, but that's an area of active interest. And you can imagine that companies are actively looking at multivalent approaches to going after different proteins, so that we're not so vulnerable to just the spike protein having the immune response.
We had a number of questions around, and I know there's been a lot of talk, as you get older, your immune system is not as strong. We know that, especially with older, frail folks. But for the group here, does the vaccine have the same impact on everybody, right? They've talked a lot about maybe minorities not having the same impact from the vaccine. Can you add any context to that?
So I was struck in looking at the data that there is remarkably high protection rates across the different demographic groups and also by age. That was another surprise. We were anticipating a profile that would look more like the yearly influenza vaccine. And keep in mind, that's killed virus grown in eggs and not the messenger RNA strategy. And people were gratified to see the level of protection that older adults that participated in the trial were able to achieve. Now, there are not a lot of data to define this perfectly, and so we're still looking at this very carefully, because the majority of individuals, the volunteers on these trials, were younger people. But I was very pleased to see that it was trending in the right direction for protecting older people as well.
That is very good news.
It sure is.
No doubt. Okay. Well, let me shift gears. We got a lot of questions, and we'll come back to some of the science, but we got a little bedrock on the science now. So I want to move to the real bread and butter, which I know we have lots of questions about. And Dr. Conant, you're now been observing this in real time happening in communities, not yet in Corte Madera, but probably elsewhere. And I thought maybe you could give us a little bit of an overview of what the on the ground is like. And I know this group is going to have a lot of questions about the tactical aspects of the vaccine, and we'll get into that, but I'll kick it to you for a few minutes.
Sure. So UCSF has been doing a lot of vaccinations. We're doing about 1,700 a day at this point. So we're rolling it out to the UCSF healthcare workforce. And I got mine on Monday. So I can give you firsthand experience that, yes, it does make your arm a little sore, but no worse than the flu vaccine. So expected side effects are generally very mild. So just like with any vaccine, your arm is going to be sore because we poked a hole in it. You may also have some aches, a little bit of fever, some fatigue or headache, things that Dr. Sivers mentioned. And I would strongly remind people that if you get some of these side effects, it's a good sign. It means that your immune system is responding to the prompt and is generating antibodies. Those usually go away within a day. And if you're worried, you can take a little ibuprofen or Tylenol ahead of time. And often that makes you have no symptoms at all. We do have people stick around for 15 minutes after the vaccine. This is not an uncommon recommendation for any vaccine. When I vaccinate people with flu, I do it at the beginning of my visit, so I'm sitting with them for a few minutes to make sure that they don't have a reaction. If you are going to have a bad reaction, it's usually in that first 15 minutes. So what we're doing in our clinics now with the COVID vaccine is we have a line of chairs in the hall, and after you get your vaccine, you set a 15-minute timer on your phone, and we ask you to sit in the chair for 15 minutes. And if all is well, then you just go when your alarm goes off. With the drive-in clinics that we're having, we're asking people to stay in the parking lot. What we don't want to have happen is somebody immediately drive away and get on the freeway and then feel a little funny or maybe be a little faint or a little worried. I don't want you driving. So we just ask again that you stick around in the parking lot for 15 minutes before you take off to go about your business. When we do flu clinics in the buildings, people are in the building and you're going to be in the building for your entire shift. So you may not have even really noticed that we want you to stick around because you're kind of a captive audience. A reminder too that you are going to need 2 doses. At this point, you're going to get this lovely card which has exactly which vaccine you got and what day you got it. And that's going to tell you what day you need to get the second vaccine. This is going to be your get out of jail free card. I'm anticipating that these proof of vaccination cards are going to be really valuable. As Chris mentioned, a lot of workplaces are struggling with, do we require it? Do we strongly encourage it? Is it going to be a condition of employment? Is it going to be required for travel? I think we're going to see people saying, you can't come unless you can prove to me that you've been vaccinated. So these cards are going to be really valuable. And I think one of the strongest reasons for getting the vaccine is to make sure that you have as much freedom of movement and employment as possible. And the other thing is, this is early access. I cannot tell you how many messages I get every single day asking, when can I get the vaccine? When can my mom get the vaccine? When can the caregivers get the vaccine? You guys are so lucky to have access to this so early. So I'm so glad that you can take advantage of that.
Yeah, we are too. So let me, a couple of questions for you. You've watched this happen now 1,700 times a day. What are you seeing in terms of reactions? Is what we talked about with Eric kind of your experience, or are you seeing things happen? What do you think? What you're thinking?
Our experience, like I said, is we've really had no severe adverse effects at all. We've had a few people who felt a little worried and faint. We've had a lot of sore arms. So that has been sort of the extent of it.
Right. And so I get my shot. I come, I go home and I wait my 15 minutes and I go home. What happens, so I'm looking at a decision tree that we've shared with everybody in the communities, or we will share with them soon, about what is, if you get a reaction the next day, meaning you have some symptoms, right? How do you know whether your symptoms are just a reaction to the vaccine versus I have COVID and I should not come to work? Is there a good golden rule there?
That is a great question and something that we're really struggling with. You've probably seen some of the media reports that there have been people who have had COVID infections at the time of their vaccination and they didn't know it. So they end up testing positive within a day or two after having gotten the vaccine. So just like any symptoms, we don't want people coming to work with symptoms. If you have symptoms, you should stay home. And one of the things that we are doing at UCSF is we are randomizing units so that not everybody's getting it on the same day. because we don't want to take out the entire emergency department staff on a Tuesday if they all got it on Monday. So it might be that staggering appointments might be a good idea, because if you have a fever, I don't want you to come to work. And I don't care if it's from the vaccine or from a potential infection. I don't want you here if you're febrile.
Yeah, thank you for that. As I said, we've got a decision tree that we have given to all of our communities, because inevitably there are going to be people who wake up that next day and have a symptom. But we've got a pretty clear guide as to how to work with your care director or your GM to decide whether you should come to work. And if you have a fever, you should definitely not come to work, no doubt about it. You brought up a question, Becky, that came up and that is, if I have COVID and I don't know it and I get the vaccine, is there any health issue with that?
No.
Great. Okay. There's been a lot of talk about, you can't get the vaccine if you've been tested for positive for COVID within 14 days, and we've got a clear protocol on that. But we had a lot of questions about that. Well, let's jump into some of the questions that you gave us. Pregnancy. If I'm pregnant, can I take the vaccine?
Great question. And Eric, you can jump in on this too. We didn't include pregnant women in the trials. That's not usually one of the goals. So that is data that we are still collecting. I will tell you, at UCSF, we are recommending that pregnant women and lactating women get the vaccine. We're more concerned about them having a COVID infection than them having the vaccine. So while the letter of the recommendation says, please talk to your doctor, as the doctor who's fielding all of these questions, I will tell you, I'd much rather you get the vaccine than get the infection.
That's great. And that's exactly our guidance as well at Aegis. So I'm glad we're synced up there. Allergies, right? So there's been all this talk, and we just talked about the low number of issues that have come out of allergies. But if I have had some allergic reactions in the past, how do I evaluate whether I should take the vaccine if I'm here at Aegis?
So, and again, Eric, feel free to jump in here. Our guidelines are severe allergies. If you've had anaphylaxis, you carry an EpiPen with you when you go out in the world. Those are the allergic reactions that we're worried about. Again, it doesn't mean that you can't get the vaccine, but you should alert the staff that you have had allergic reactions in the past so that they can be ready and available. All of the vaccine distribution sites have EpiPens available and are prepared for that, because it is a very rare but possible problem. But just general allergies, if you are allergic to, pine dust or something like that, those are not the allergies we're talking about.
Yeah. Well, we are prepared with EpiPens both through CVS and within our own community. So we're definitely prepared, but I think that's great guidance. So I've gotten the vaccine now, and I think I'm good. I could still get it. Can I still transmit it?
We don't know that for sure, but we worry that you can. So remember that only 95% of people are protected, and the protection is really from serious illness or death. So you may still get colonized with the virus. It might still get into your nose and mouth and replicate some before your immune system protects you so that you don't get sick, but you might still be able to sneeze or breathe it out, which is why we are recommending everyone continue to wear a mask, to wash your hands, and to socially distance even after having gotten the vaccine.
So what I heard you say is that you can still have it and you can still transmit it. And I'm guessing that we're going to need to continue to be very, very cautious for a long time to come.
Yes, but you're not going to get super sick, and you're not going to end up at the hospital, and hopefully you wouldn't die.
I wonder if you could react. I'm jumping around here a little bit, but Dr. Fauci was on NPR this morning, and I was listening on the way in, and he was suggesting that I love Dr. Fauci. I'm sure you do too. He seems to have all the answers all the time. But he was suggesting that he thought that by April or early May we would see broad access to the vaccine in the United States, and that probably by August or September we could potentially be back to a place where things were, I'm going to say normal, but more normal than they have been. Do either of you agree with that timeline?
I hope so. Yes. That's the timeline that we are all optimistically hoping for.
Yeah,
Chris, I
support that too. Yeah.
Chris, I was going to circle back to a question that I get a lot, which is, do you need to get vaccinated if you've had the infection? So a number of people in the communities have had have had the virus and they've tested positive. And just to make sure that I'm very clear in saying, yes, we don't know how long the immunity after infection is sustained. And so we want people to get the vaccine, even if they have had the infection.
Yeah,
There was also
another. Go ahead, sir.
There was also an interesting question on the side about if anyone's had a recent infection or had antibodies, either the Regeneron or the Lilly antibody infusion for an infection. The vaccine probably is going to work best if it's at least 90 days after either of those. So, and the reason for this is that we want the immune system to see the spike protein and make an immune reaction. And if the spike protein is just quickly neutralized by antibodies that were given in an intravenous infusion, then it's not getting to do that vaccine effect. So roughly 90 days is a guidance that that I have heard for that.
That's great. We actually have a couple questions related to that. So can someone get the vaccine after receiving convalescent plasma after being treated for COVID-19?
I would say 90 days. Rebecca, what are your thoughts?
I agree. I don't think we really know, but 90 days is a good number to start with.
Okay, great. Will staff and residents still require COVID testing after receiving the vaccine? I think we've answered this, but I just want to make sure I'm honoring the question.
Yes, because remember, you can still get the virus in your nose and replicate it. Even if you're not getting sick, you could potentially transmit it.
Absolutely. Can we address the 2-shot thing? So we had a question here, we read the newspaper that instead of 2 shots, that maybe we'd be okay with 1. Very odd conversation. Is this something that you think is real that we may be transitioning to, or is this just sort of fodder in the media? Is that a real conversation?
Eric, I'm going to punt to you on that one.
Okay. I think this is a public health matter, and for everyone assembled on this call and for the residents, I am absolutely supportive of 2 shots following exactly the guidelines from Moderna and Pfizer. Now, with that said, and with that clear foundation, and I say that because you've got to absolutely protect against serious illness and death in the populations that we're serving. There is justification that I think is very reasonable for the UK healthcare system in a crisis that they're facing, to give a single dose and not hold the other dose in the freezer for individuals, but to get as many, what they call them, jabs in the United Kingdom, jabs in arms as quickly as possible, and then follow up when you can so that you can get people fully protected. But that's a public health matter. And that's a matter for, for instance, my son, who's 21, he's an EMT, and he's going to get the vaccine, but he wrote an editorial that he was willing to give his second dose to someone else today. But he's 21, he has no comorbidities, and that is a reasonable public health perspective to try to get more people vaccinated soon. And so I think from a public health perspective, I fully understand the rationale for that. It's not at all crazy in my mind. But from a perspective of the community assembled here today, and what your guidance is, I'm absolutely on board with getting both doses and doing everything you can to follow it per the label.
Seems like a good time to follow the label. I agree with you, Eric. Okay, thank you.
Hey, Chris, this is Dwayne. I have
Yeah.
a question that I wanted just to ask Rebecca and Eric, because it's a question I get a lot, and it's the the Pfizer 95% efficacy and the Moderna, I think it's what, 94.5 or something like that efficacy. And it's confusing to a lot of people, myself included. Does that mean 95% of the time it's effective to prevent serious illness or death? And so does that mean if you get vaccinated, 5% of the people are still going to get serious illness and die? Or it's 95% effective in terms of for all people? Do you understand the question?
I think I do. The way that I've understood it and had it characterized is that number comes from events on a clinical trial. So the 30,000 subject clinical trial that as 100 events occur, 95 partitioned to the placebo and 5 partitioned to the vaccine arm. And to also keep in mind that that doesn't mean that it's severe illness and death. It just means an event per the 2 trials. And there are slightly different definitions of what constitutes an event, you know, for each of those trials. So does that help at all?
Yeah, I'm just trying to clarify because I get asked this question a lot. Obviously, I'm not a doctor like the two of you, but I don't know how to explain that because people always say, well, does that mean 5% of the people that get vaccinated still have a chance of getting severely ill and dying?
It wouldn't just be 5% of people vaccinated because that wouldn't include an exposure, a meaningful exposure, and all events weren't necessarily severe illness and death. So because I think an event was constituted a febrile illness with documented COVID-19 infection.
Yeah, but and I guess it's really too early to know if you're vaccinated, can it really result in death if you get COVID after vaccination? We don't have the data or the people or the human trials to really answer that question yet.
I don't think we do, but I think statistically that's exceptionally unlikely.
Good.
And actually, I think that the data actually were that there were no deaths on the vaccine arm.
Yeah, and there were people that got COVID that did the trials. Isn't that correct?
Oh yeah, that sadly one of the benefits of running it fast in the United States was that the COVID rates were out of control, and they very rapidly reached the number of events that led to, you know, this lucky day today where you're kicking off a vaccine program. If COVID was brought under control, we wouldn't be having this meeting today. It would be probably sometime in March or April.
Right.
But because it was just so out of control in these populations that were under study, you know, those death rates that clicked off, you know, getting to 100, for instance, triggered the meeting of the Data Safety and Monitoring Board for each of these trials, and that happened very quickly.
And isn't it true, Eric, that some of the placebo people who in fact got COVID did in fact die? Weren't there a few deaths?
Yes.
Yeah.
So Dwayne, I'll jump in and say I agree with you as a clinician, not a researcher. The 95% is hard to explain because it has to do with how the trial was run and how they're looking at the data. But the way to think about it is it's an incredibly effective vaccine. And if you get it, you are extremely unlikely to get sick, much less seriously sick or die.
Yeah, no, I appreciate that. And I just wanted to clarify that because that gets brought up a lot. And I'm super optimistic about it. And, you know, we hear a lot in social media about being in the 1% club. I think Aegis has just joined the 1% club because there's less than, I think, about 4.5 million people that have taken it out of our 337 million. So all of you on this call has just joined the 1% club. So congratulations. Chris, I'm sorry to interrupt. Go ahead.
Not at all. Well, I'm just going to tick through some of these we have on the text on the chat here, and just to clear up just a little confusion, just back to the 90 days, Eric. The 90 days is not about if you've had COVID. So we have a clear protocol on who's vaccinated, which is, and you all can validate this, right? As long as you're not testing positive for COVID currently and have been out of the woods for 14 days, you can accept the vaccine. I think that's the guidance, correct?
Yes.
Okay. Excellent. So we're really clear on that. A couple other just tactical questions. If I think we've covered this, but I'll just do it again. If you've had COVID, do you still need the vaccine?
Yes.
Yes. Clear answer there. Any issues with mixing medications with the vaccine? Any watch outs there? If you
No.
have other medications that you're taking?
No.
Becky, you're my favorite doctor. It's just like, you just on it. What medical conditions, we talked a little bit about this when we were talking about allergies, but what medical conditions should I worry about if I'm getting ready to take the vaccine? We talked a little bit about the history with allergies, but any other conditions that come up that warrant some review with your doctor?
So we do worry a little bit about people who are immunocompromised, but again, we are very worried about them getting COVID infection. So we really don't have any hard and fast rules about people who should not get the vaccine. I think if you have a medical condition and you're concerned, please ask your physician for their guidance. But UCSF does not have any conditions that are a hard stop to getting it.
Okay, great. Super strain. Eric, you talked about that earlier about the South Africa and the UK sort of mutation. Anything else you want to add to sort of how we think about that and where that may go in terms of how it relates to the vaccine?
Sure. The fear is that the mutations will render the vaccine less effective and less protective. And so this is an area of active public health interest, and vaccine makers are considering this very carefully. It's just another reason to try to get as many people vaccinated and protected as possible, as quickly as possible, so that because these mutations arise when the vaccine is out of control in communities, spreading and having a lot of opportunity to mutate, and it doesn't have opportunity to mutate when it doesn't infect new people.
Okay, well, we'll see, I guess. Hopefully we'll, again, it's a game changer, right? We're privileged to get it and try to get as many arms as we can. Why have we not figured out if this is safe for kids? Just because it's not tested? Is it safe for kids?
It's not tested, so it's not known. It is very likely safe for kids, but I want to be really clear as a pediatrician as well. The risk benefit for kids is meaningfully different than it is for an 85-year-old. So I think it's going to be a while before we do the vaccination in children. As everyone knows, kids are exceptionally unlikely to have serious illness or death. And so vaccination of children is really a matter of public health and trying to protect the adults and older people around them.
Great. So I'm going to open it up here. We've got about 10 minutes left. And Eric Smith, who's our vaccine task force czar, as I like to call him, we just had one question here that I'm going to ask him to answer. This is an easy one. Will we receive additional vaccinations after the scheduled clinic to administer to new move-ins? You want to take that one, Eric?
Yeah, great question. We always love it when people are thinking as far forward as possible. So there's likely going to be a gap between receiving the vaccine clinics in-house and then when the vaccines become widely available. And so the question, I think, at the heart of that is how do we manage new residents, new staff members, and people who could be introducing risk into the community because they haven't yet been vaccinated. This is something that we're still very much working on. We know that there's going to be a partnership with our Mercury Pharmacy in Washington State, and we also know that there are going to be opportunities at a county level in California. It's difficult to answer anything more specifically than that, but the guidance is going to be to get as many folks vaccinated as quickly as possible and save, the third clinic, for example, for any new residents or new employees who haven't yet been vaccinated, after the first two clinics. And then we're going to work with folks on on an individual basis, right, a community basis, to understand what are the best options moving forward. And if I could just clarify with the doctors on the call, our understanding right now is that there's no upper limit to when the second injection can be taken. The only thing we have to worry about is not getting the second vaccine too soon.
Yes.
Correct.
Excellent, great clarification. Although we want to make sure that, you know, you GMs on the call, you own that process. And I just want to make that really clear that you are accountable for making sure that those folks, both residents and teams, get that second dose and that we get it on the schedule that we can get it on, right? Because I think our great worry is we've got these 3 clinics we're scheduling, but who knows when the vaccine will be widely available. So we've got to execute on those clinics that we know are going to happen. One big question, you know, the science question here that I'm happy someone asked, you know, if you can still get COVID and be contagious after having the vaccine, then how does the vaccine protect everyone around you? Maybe that's the herd immunity question, Eric, that you could give us a little science on.
Yeah, and I want to be really clear that when we don't know something from a research perspective, that doesn't mean that the opposite is true, that vaccinated people can freely spread it. The guidance that we're giving is based on being cautious. It is widely believed by vaccine researchers that vaccinations will prevent transmissibility. But I want to be really clear, the 2 large trials that were done did not have that as endpoints. We didn't test that in those big trials. Whether that people were actually able to transmit it to other people. That's a complicated trial to do involving viral culture and looking very closely at epidemiology of contacts. It is widely believed that the vaccine will help us reach herd immunity, which people believe is roughly 60–70% of people that will not get a symptomatic infection. Also think about this. If you don't have a symptomatic infection, meaning you're not coughing, then it's a little bit less likely to be transmitting the virus to those around you. And so there's really still wide belief that it will help avoid transmissibility, but we're being cautious until we have more data to support this. Becky, any additional comments?
No, I think I agree with you. We don't know the answer to that. That is still an open question, and time will tell.
Well, you can bet that we're going to continue to be very cautious at Aegis, right? In these coming months, as much as we'd like to say, gosh, let's open it all up, we're going to have to continue to be cautious. And I'm sure that it's not like once we get all the vaccines that everybody's going to come swooping back in. We're going to have to be careful. And that is our #1 responsibility, to keep these folks safe. And you ask about the 3rd clinic and how those individuals in the second vaccination get the 3rd clinic get the second vaccination. The hope is that by then CVS, you'll be able to go to a CVS with a letter and say, I've had the first vaccination, I now need to get my second. But that's not, you know, we still got to work that out. So we'll let you know as soon as we have more information on that. I'm going to open it up real quick here because I want to make sure we didn't miss anybody that had a burning question, because this is our opportunity. We've got experts on the phone, and this is our chance to ask it. So I'll just open it up to the group, and anyone who's got a question, please maybe raise your hand and ask your question.
Hey, Chris, it's Dwayne again. I'm sorry.
Sure.
I love data, so pardon me. But we're vaccinating right now in the U.S. at a rate of about 500,000 people a day, which is better than we were doing 10 days ago. So we're making progress. But you don't have to be a math expert to know that at 500,000 a day to reach herd immunity is 70%. You know, that's going to take us a year and a half to get everybody vaccinated. So obviously the distribution of vaccines, the injections of vaccines is going to pick up. And I think the CDC and others are saying that we have to get north of $1 million vaccinations a day to get to the place that we want to be to reach it. I'm just wondering between Eric and Rebecca, I'm wondering about how natural herd immunity coupled with vaccination, where those two axes meet. And so we know places like North Dakota, South Dakota, El Paso County have seen herd immunity within those cultures, and their caseloads are starting to drop even during the holidays. And at Aegis, we've had places where we've had 80-unit buildings where between staff and residents, we've had 60, 70 people get it. I'm just wondering, is there a place where that natural vaccination of having COVID meets with the vaccinated people, and those two axes meet and it shortens the curve? Do you understand the question? Have you seen any projections where, we may reach herd immunity between natural COVID cases and the vaccinations by April?
Rebecca, do you want to?
Well, I'm happy to share the answer with you. I think we don't know, as a short answer. Certainly having a group of people who have been infected and have some immunity is helpful. But remember, we do not know how long and how sustained that natural immunity after infection will last. And is that protective? We're seeing more and more cases where people are getting a second COVID infection, which suggests that it is not sustained. And that is where the recommendation is that even if you've had a COVID infection, we still want you to get vaccinated to boost that immunity so that you will not get it again. How that plays into the timing is really complicated, and I'm not sure how to really project forward. I don't think that's my area of expertise. So Eric, if you'd like to do that, please feel free.
Yeah, I've seen some curves that attempt to integrate both the natural infection immunity and vaccination that steadily rises in reaching that magical 70%. So there are some communities, as you mentioned, Dwayne, where the natural rate is so high already that vaccines, that they're already there. They're not that many of those places, but they certainly are present in the US. And but the bottom line in terms of what we do is to get as many people vaccinated as possible, and then look for these very high rates of transmission to drop precipitously. And then the ongoing question is just what kind of diligence we're going to need to have over 6, 9, 12 months from now when waning immunity begins to occur, so that we don't see new outbreaks occurring because the vaccine immunity is waning. It's also not at all known whether waning immunity will be associated with serious or life-threatening infections, or whether they'll just be symptomatic again. Huge amount of things that we just have no idea, because this is just rolling out now and there's not that kind of follow-up yet.
Yeah, I think the zillion-dollar question is this an exercise like painting the Golden Gate Bridge? When you get done with one side, it's time to start and go back and paint the other side. And so if it's true that vaccines only last 6 to 9 months, and we're getting vaccinated now, and it takes another 9 months to roll out the vaccines to another, well, call it 200 and some million people, then we're going to start having to vaccinate all over again with the people that we vaccinated in December and January in 9 months.
That's conceivable.
Yeah. Okay.
I also want to bring up one question which I saw in the chat, which is, why are we still wearing masks? And I'd like to quote one of my colleagues here at UCSF who's been doing a bunch of research and showing that wearing a mask definitely lowers the viral transmission. So even if you get a symptomatic infection, if both individuals are wearing masks, it seems that the severity of that is much less. And so there is still value in wearing masks. If it doesn't prevent 100%, at least it is helping. So this is another reason why we are going to continue to wear masks for much of 2021. So I encourage you to pick some, lovely, Etsy vendors and pick your favorite mask and get something fun, because we're going to be wearing them out in the community much of the year.
Ann Christensen, you had that question down in Dana Point, California.
Okay. Oh, let me hang up on the concierge, sorry. I would just like to ask for those that have an autoimmune, maybe are going through a treatment for cancer or whatever it might be. I know we touched on it. In the clinical trial of those that went through, were there any participants that had underlying medical conditions of autoimmune or currently in treatment?
Rebecca, do you have that answer?
I have not looked at that level of detail of the trials. Eric, do you know?
Yeah, I don't have that either. I seem to recall that some there was an attempt to get some data on people that had autoimmune diseases and that were on some steroids, and that they were able to mount a response. But I think that the key simplicity of the guidance is that whether someone has cancer, whether they are on chronic autoimmune medications, it's to go ahead and vaccinate, because failure to vaccinate is associated with greater risk than the vaccine itself. The thing to remember is that immunosuppressed individuals may have a lower protection, and it's harder for immunosuppressed people to mount a protective immune response. But that doesn't mean that they're at greater risk from the vaccine. They're at risk really from COVID infection.
Thank you.
Yeah, I'll say that the concern is really, what is the response to the vaccine? Like, are you going to be protected? Not, are you going to have a bad side effect?
Right. If you got that situation, talk to your doctor. So we get good, you get a good, thinking through. We have time for just one more question. Any questions out there that didn't get asked? Jeffrey Davis.
Chris, I just want to make a point. I'm sorry, I feel like I'm yelling at you. I'm technically challenged, so you tell me to quiet down if I am.
Never.
I just want to add to what the doctors have responded to, and our colleague in Dana Point. I'm present, some of you know, I think I might be the oldest person in our company, perhaps. I'm in the middle of a second study trial at Swedish Cancer Institute. And I have CLL, chronic lymphocytic leukemia. I'm doing great. I'm the poster boy at Swedish. So there's no bad news here, but I talked to my oncologist several days ago. We're taking care of my cancer with pills now. I take 2 pills a day. I went through chemotherapy and radiation and all that years ago. I've been doing this for about 11 years. And I'm in a study trial, world-class study trial. And he, Dr. John Pagel is his name at Swedish, wonderful man, great talent. And he gave me the green light because I wasn't about to jump into something. I wanted to, but I've learned, because I have a doctor daughter as well, I don't listen to her as a doctor as much as I do as a daughter. So let's get that clear. But Dr. Pagel said, oh yeah, you got the green light. We want you to have it. And I'm going in for my monthly CR scans and the EKGs and all the other stuff. And I'm doing great. I just pass it on because you can use me as a case study. I'm going to get it and get the shot, the jab. And if I'm still standing the next day, please circulate that wonderful news around the community, okay? Because the oldest guy in the company that's compromised and has cancer is walking around now, and I'll keep wearing my masks, but the mask. But I just wanted to add that to it. It's not a question. I'm sorry I took too long, but I wanted you to have that input.
Jeffrey, thank you for that. And we will make you a star. I promise. Angie will note that, and we will, we need to find out where you're going to get the vaccine, because we're going to put you on TV. Thank you for that.
Oh,
Listen, I want to be really,
Yeah.
sorry. I want to be respectful of everybody's time. We've used our hour, and I think this has been a very, very helpful exercise to go through. I want to thank Dr. Sivers, Dr. Conant, Eric, others that have really, put us in a position to be successful right here, because, we've got 6 million Americans out there with this vaccine in their bodies right now. We've seen very little issues so far. We've been through a lot of that, right? We know that this is a game changer for us at Aegis. This is what is going to allow our residents, to get out of their rooms and see their family. And it'll take some time, but we're going to get there. And this is our opportunity. So over the next couple of weeks, which I really believe for most of it's going to be in the next 2 weeks, we're going to be able to vaccinate a large portion of our group here at Aegis. And as you, Eric, said very well, it is a privilege. It is a great privilege to be at the front of the line, and we do not take that for granted. So Dr. Sivers, Dr. Conant, thank you very, very much, not only for your time here today, but you have been remarkably helpful in advising us of clinically how to work our way through this virus. And I think a lot of our success is in credit to you for your help. So I can't say thank you enough for your time today and all your help for Aegis. And to everybody on the phone, thank you. Keep the faith. The light is very bright coming down the tunnel right now. And again, your GM's got a bunch of information today, along with your HSDs, on the vaccine, how to prepare your community for it. If you have any questions we did not get to today, I will either follow up with you or call me. You've got some great resources in Eric Smith, in Katie Webb, in Julie in nursing. We are all here to help you and available to you 24 hours a day as we go through this very important time. So thank you for your time. Thank you for all you do for Aegis, and really good to see everybody. I think there's a lot of optimism on the horizon, and we got to take advantage of that. So thank you guys. Dwayne, anything to add from you, by the way?
No, I think it's a great call. Thank you, Rebecca and Eric, for doing it. You've advanced our knowledge tremendously. I'm just delighted that we're in this privileged position of getting a vaccine for all our staff and all our residents. I just think we're tremendously fortunate, and we're going to keep being socially distant and wearing a mask and washing our hands and getting through this. And just want to thank all the heroes on this call for the job they do on a daily basis. It's been remarkable that we've done as well as we have. So thank you.
Thanks, guys. Nice to see you all. Have a great week, and your date is coming soon. Nice to see you guys. Thank you, guys.
Blessings.
Thank you.
Thank you.
Blessings.